Good evening, everybody. Welcome to this ESU course webinar online. I think it's an honor to address you on the topics that's new in the guidelines from renal, bladder, and prostate cancer. We have an esteemed panel here. José Domínguez Escrich from Valencia, Spain will update you on bladder cancer. Alessandro Volpe from Novara, Italy will update you on kidney cancer, and I will finish, if time allows, with the prostate cancer update. First, I'd like to address a couple of household remarks. We want to be brief and precise on the updates. So we will have a presentation of 15 minutes. And after that, we'll address the questions that come in with the Q&A that you can address us to in 5 minutes, if time allows. We have some time spent after 8 o'clock if needed, but we'll try to be as brief as possible and address all the questions that you may have. Please remember that this 1 hour seminar is awarded with 1 point CME only when you finish the questions after the course that are presented online. And I would like to continue with introducing Dr. José Domínguez Escrich from Spain on bladder cancer, and I will ask him to share his slides.
There we are. Good afternoon, everybody. My name is José Domínguez from Valencia, and it's my turn to talk about the update on bladder cancer. And obviously, due to time restraints, I'm going to go only to the very, very new things that have been in the non-muscle invasive and the muscle invasive guideline. I'm going to scroll here. Sorry, I'm having a bit of problem. I have no conflicts of interest. And let's start with the non-muscle invasive bladder cancer. Well, additional data has been included throughout the text, particularly in chapter 4, with a huge amount of work and changes on the histological grading of non-muscle invasive, with a new section, the prognostic value of histological grading, as well as a new summary of evidence. And this reflects the evidence from possibly the 3 most important papers that we have included in this update. The first one is a large systematic review and meta-analysis that was published by Victor Sokop recently, and which clearly demonstrated there was no difference between the 2004-2016 when comparing with the grading classification of the 1973. And this is now included in this statement on the summary of evidence, when clearly says that histological grading of non-muscle invasive is classified according to either the 1973, the old G1, G2, G3 classification, or the 2004-2016. The second paper also included is a large inpatient data, very elaborated paper published by Bas van Rijn and European Urology just this year. And this was an IPD analysis with more than 5,000 primary Ta81 tumors collected across 17 centers in Europe and Canada. And the findings are also included in this evidence, as in both the WHO's 1973 as well as the 2004 classification systems are prognostic for progression, but not for recurrence. And this is one of the key points now. Second, the WHO 1973, it turns out to be a stronger prognosticator for prognosis than is the new 2004-2016. Nevertheless, if we use the 4-tier combination, putting the low-grade G1, the low-grade G2, the high-grade G2, and the high-grade G3, both classifications is superior to any of the 2 classifications alone. Finally, sub-analysis of the large series from Sylvester with 3,000 cases with primary TA also demonstrated that, look, this is the, as you know, papillary urothelial neoplasia of low malignant potential. These lesions have the same prognosis than the TAG1, and therefore, from now on, we have to consider them as low-grade TA tumors in terms of prognosis and management. And this is also one of the improvements. So in terms of recommendations, again, to use the 2017 TNM for staging, to use both the 1973 and the 2004 for a classification of the grading. And please, please, please do not use the term superficial bladder cancer. This is a personal fight we have with this. Now, important as well, chapter 6 has basically completely reviewed, and predicting disease recurrence and progression has been revised and based on the findings of a very large IPD run by the same EAU guidelines panel with Richard Sylvester at the front. We have now established new groups, classification risk, and also established a table addressing the probabilities of disease progression. And those are the ones that need to be relevant here. As you can see, this is the new risk classification, probably the most important thing of this talk. Primary single Ta81, less than 3 in less than 70 years. That's what we know as a low risk. Primary Ta low grade without CIS, with maximum one of the added risk factors. And high risk, all the T1, G3s that we had, but be very careful with this. Now we enter these factors that need to consider age more than 70, multifocality, and tumor diameter. That makes possible that TA high grade end up to be a very high risk tumor now. You can calculate the risk, and we can do that as well using the new EAU calculator, which you can download, and it's also now mobile. You can get it from the WWN non-muscle invasive bladder cancer net, and it's very easy to use. I've just done a simulation here. Sorry, this will be more than 70 years old with a primary single tumor more than 3 centimeters, T1 with CIS. You can select either the 2004 or the 1973. I choose the old G3, and this is my risk calculation, which you can also implement. And I think we need to include this in our medical records, and I think it's very useful to present to the patients. Then the most important thing, how we manage these patients with the new classifications. Well, no big changes here. For the low risk, single dose instillation, that's all we need. If we have an intermediate risk, we need to go for either mitomycin, well, chemotherapy, or BCG for 1 year at least. If we go for the high risk, in those cases, we are talking of full dose BCG instillation from 1 to 3 years, or radical cystectomy. And definitely for the very high risk, and that's why I insisted earlier, because now a very high risk can be a PTA G3, the treatment should be radical cystectomy. And only in those cases that refuse cystectomy or are unfit for it, we should consider some sort of bladder preservation. I will not go through this. This actually belongs to last year. That was the redefinition of BCG refractory and BCG unresponsive, as agreed with the FDA. And this is the plan of treatment. How we manage these categories? What happens when the patient fails BCG? Well, if we have BCG unresponding, radical cystectomy. We can enroll them in trials. Several of them are running at the moment, and this is probably very important, and we are going to hear a lot more about this in the next few years, so probably in the next few months, because this is going so fast. And consider bladder preservation strategies in those patients which are not suitable for radical cystectomy or cannot go into any trials. Late BCG relapsing, again, radical cystectomy at front. We have to insist on that. Alternatively, you can repeat the BCG course, but very important, always document. This is my what I tell the residents, always document you offer cystectomy and the patient didn't want it. Okay, we need to offer it. Even for patients with low grade recurrence, this is not a failure of BCG. We can consider intravesical therapy, but careful, it's always an option, radical cystectomy. The one thing you are going to see in the next few years is we are becoming more aggressive in how we manage BCG failure. And in terms of follow-up, the recommendations, very important. Insisting again, we need regular cystoscopy, okay? The follow-up of these patients is based on cystoscopy. What happens? If you have a low-risk tumor, you can do a cystoscopy at 3 months, and if it's okay, you do one more at 9 months, and then yearly after for 5 years. If you have a high risk, you need to do the 3-monthly one, and then the guideline recommends 3 monthly for 2 years, then 6 monthly for another 3 till 5, and then yearly till 10. And I've done a small drawing here myself. I hope you see it more clearly. This is the plan. We still have one issue with the guideline, is how we follow up the intermediate risk. Is this none of the low, none of the high? And I always, me being brave, this is my personal protocol. This is completely out of the guideline, okay? I think we need to go something in between, but this is definitely, please, this is not the guideline message. And of course, we need to keep follow-up of the upper tract. Yearly CT IVU or IVU is recommended for high risk and the very high risk, okay? Endoscopy, wherever we need suspicious or high grade, needs to be done. And of course, if we get a cytology which is positive and we have no evidence, we need to use biopsies in theater. We can also use PDD if this is available. And this is pretty much what we have for the low grade. Going to the muscle invasive bladder cancer now, well, I have to say that new relevant references have now been included in this new review for the 2021 update. Having said that, a part of the management of the metastatic disease, I think is much lighter for this year. There was a lot of changes implemented on the 2020, and as you will see here, there are some minor corrections, as you will see, and those are the one included, okay. The first one, guidelines on the assessment. Here, basically, we always explain the urologists how to document the sites, how to inform the tumor sites, the pathologies when we are sending the samples. Well, we have expanded this a bit more, and we specify which is the information we need. And we need to record the depth of the invasion. We need to record the margins, particularly important if we are looking at radical margin, prostate, urethra, the ureters. Record the total number of the lymph node, not just to say 1 or 2 positive. I want to know how many. This is a quality of the cystectomy. Record lymphatic and blood vessel invasive, has prognostic value, and of course the presence of carcinoma in situ. This is one of the slides that have been updated this year. Again, summary of evidence, primary assessment, again and again and again. Cystoscopy is the key for the diagnosis, and urine cytology has also a very high sensitivity in high-grade tumors, including carcinoma in situ. What will happen as well, and very important, the role of the biopsy. This has been expanded. To be honest, the slide scares a bit, but it says the same as before. We need to do prostatic urethral biopsy. Please do prostatic urethral biopsy. This is going to condition the management of the patient if you are going to do a cystectomy. And one of the new things, probably taking into account this holistic approach, something very important. The patient is more than just the bladder. There is a man or a woman around it, and we need to take this into account, okay? Very important, the concept of frailty, and always apply the clinical frailty scale of the G8 screening tool. You have them available in the guideline. Just apply it, give it to the patients, and record the results. It's very important to assess the patient. Changes as well regarding markers, very simple. We don't have markers yet. We don't have the evidence, but 2 situations have now been recommended. Evaluate PD-L1 expression in those patients that have had no previous treatment, okay, and have locally advanced or metastatic disease, and you are considering to give them pembrolizumab or atezo before chemo. And second scenario, patients that have already received chemo and have failed, and you might consider erdafitinib. In those cases, it's recommended to check the status of the FGFR2 and 3. Only these 2 cases are now recommended in the guideline. Regarding radiotherapy, adjuvant, neoadjuvant, this has been reviewed. This is the original article. That was a systematic review with 5 studies. One of them was actually the one that skewed all the stats, and then the other two were contradicting each other. And this now has been updated with a new study. This is a prospective randomized trial of comparing postoperative versus preoperative adjuvant radiotherapy for muscle invasive. Important, I think one of the problems this is done in Egypt, fantastic surgeons, but they have 50% of the series is squamous cell carcinoma. So it's difficult to assess if this really will correlate with our purely urothelial population. And they conclude that there are no difference one or the other. The conclusion and the recommendation from the guideline then is to consider offering adjuvant radiation in addition to chemotherapy following cystectomy, but only based on pathological with high risk PT3B, PT4, or positive nodes of positive margins. That is the recommendation. And the probably most important thing, and the only thing that have changed dramatically in the last guideline, is the management of the metastatic disease. And here, very simple, first line treatment, cisplatin containing, basically IMBAC or gemcitabine cisplatin. If patient is unfit for cisplatin but can have carboplatin and gemcitabine, that will be the option. And very important as well, in patients that have achieved a stable disease or even some form of improvement, consider avelumab, the PD-L1 inhibitor, in maintenance. And this is one of the new issues. First-line treatment for unfit patients, well, we need to go to checkpoint inhibitors, pembro and atezo. The evidence here is weak. And second-line checkpoint inhibitors, pembrolizumab, to patients progressing during or after a standard platinum therapy. If this is not possible, atezo, nivo, avelumab, or durma. There are several trials, and we are going to see a lot of changes in the next few years. And of course, enrolling in clinical trials. So very simple here. This is the flow chart: platinum eligible, ineligible, clearly. If you can give cisplatin, if no, carboplatin. What happens here, based on the updated results from the keynote, assessing the role of pembro, this is an alternative now as a second line when there is progression. Another alternative will be the use of avelumab in patients that have either stable disease, complete response, or partial response as a maintenance. This is also, this switch is one of the options included. And of course, later second line, you know how many trials. I think this is going to be the Achilles heel for the next 2 or 3 updates of the muscle invasive. This is going to be changing every month. And I think that's all. Thank you very much.
Thank you, Jose. I think you were very brief and very clear. Yet I went through the Q&A, the question and answers, and I think there are some relevant questions. You may read them yourself, but I go to the first one, for example. In your risk score, you said age was an important discriminator. How do you explain that, is one of the questions.
Where are we? Age?
That age was an important predictor in the risk score for non-muscle invasive bladder cancer. What?
Well, age has been always in the panel for many years. Age has different issues here, particularly because in terms of progression, has to do a lot with the immune response that you get with age. It's one of the obviously. If we forget the impact on overall survival, because obviously other morbidities, patients that can have a lot of other problems, they might tolerate surgery worse. But we are not talking of overall survival here or the impact of age. That would be so easy. We are looking at specifically why older people tend to do worse and have worse prognosis. And this, I think, maybe is what we learned from years, but we always see that response, particularly to BCG, which has been the standard and what makes the difference here, it has something to do with the immune system. And we know that the younger people respond much better with BCG. So high-grade disease, CIS, the really nasty tumors, the ones that are going to progress and they are going to kill you, you have a better chance to respond to what has been the standard treatment. that was the BCG, always with age. So whenever we done the IPD and all the different, age is still there. But I think it's more to do with the way that you respond
to the treatment.
To BCG. Now, that would be very interesting now to see what happens with the new the checkpoint inhibitors.
Yeah, that will be similar, yeah.
Well, you would expect that. If we extrapolate that, and the figures, to be honest, go on that line so far, I'm afraid that we are going to have the same. Good news for the young guys, but still bad news. It might not work for the elderly.
Okay.
We have the same issue.
Interesting thesis, Jose. Another question: you suggested, or the guidelines now recommend to do BCG 3, 6, and 12 months. And one of the questions is, what do you do after 12 in these patients that had BCG?
Well, in patients with for intermediate risk, we are saying full dose BCG for a year. On high risk, we use is 1 year or 3. And I'm afraid this comes depending very much on where you're practicing. Right now in Spain, some hospitals are going back to the 3, but for years, since I came back from the UK back to Spain, now 10 years now, we had one after the other of these episodes of stopping BCG, having long periods of no BCG available. And then we have from the Spanish medical, the regulatory body, like the European, for the Spanish pharmaceutical companies, and saying, look, you have only 1 year. And we shifted. We are now using sort of the LAM, the Southwest Oncology Group protocol, but reduced to 1 year. So we use 6 months induction and then 3 at 3, 3 at 6, 3 at 12. And we stop that. If we can, I would like to continue, definitely for the high risk. Can you imagine a PT1G3? A PT1G3, even with CIS, that doesn't want to have a cystectomy, 1 year probably is very short. And I would feel more comfortable giving 3. Probably I would feel more comfortable giving 10. But we know that more than 3, there is no difference. The idea is, do we have BCG available? And that very much depends on where you practice. And I'm sure that among the audience will be people, colleagues, that they only allowed to use 1 year. Some of them can use 3 years. And very much depends on BCG availability at the moment, I'm afraid. It's as simple as that.
Yeah, clear. Thank you. Very clear answer, Jose. Thank you. One of the questions is regarding treatment of muscle-invasive bladder cancer, saying why, what's the opinion of the guidelines on triple therapy?
Are we talking about bladder preservation?
I think the questioner is doing so, yeah. I think he's meaning...
Yeah, I think the question of this is nothing new. We haven't really updated that very much. In terms of the bladder preservation, as long as it's done in the right context with a correct indication, the guideline has been always very supportive. Even surprised me how supportive the guideline is. But the evidence now is in favor of using TUR, chemo, radio, the triple therapy. There is no scope nowadays for using just chemo, definitely no TUR. This is one of the things that personally I'm quite passionate about, because obviously I'm practicing at the EVO and I came here with Professor Solsona. So I've been brought up with this idea of bladder preservation. We have a long experience, and Solsona here in Spain and Harry here in the States, we had the largest series on preservation just with TUR plus chemo. Even us, we have now moved to chemo radio, because I think right now is the standard. I think I'm really eager to see what's going to happen in the future, when particularly the work from Japan, showing the role of lymphadenectomy and maybe going back to partial cystectomy and all these new combinations. There is a new world there, a lot of new options that I'm sure we'll be discussing longer in the future. But yes, as long as you are strict with your patient inclusion criteria and you select the appropriate patient, it's an option. It's definitely an option.
Okay, great. Thank you for the answer, Jose. I think for the sake of time, we have to continue. But the nice thing with these online sessions is if you can open, Jose, if I can ask you, if you open the Q&A, you can see the questions, and you may find some time tonight to answer them if you type that. That would be very nice if you could do that.
Great.
So in the meantime, I think we can continue with Alessandro Volpi, who is a long-standing member already of the guidelines for renal cancer. Alessandro, please.
Thank you very much, Anke. I hope you can hear me. And it's a real privilege for me to be with you tonight to give an update on guidelines on RCC 2021. I have no conflict of interest to disclose. Of course, we will stick on the main changes that have been done this year. Regarding a diagnostic evaluation for RCC, as a panel, we assess the value of preoperative chest CT for renal cancer staging. There has been an effort by some European centers to develop a risk prediction model that was then validated and simplified. And this author came to the conclusion that actually patients with clinical T1A tumors and zero, in the absence of systemic symptoms and of anemia and thrombocytopenia, actually have an almost negligible risk of harboring metastatic disease in the lungs. And therefore, there is now a weak recommendation to omit chest CT in these patients due to the low risk of lung metastasis. This is an important message that the guidelines this year is sending to all urologists. We also investigating the behavior of a non-RCC tumor, renal tumor, angiomyolipoma, and as a panel, we actually came out with a systematic review of the available evidence. We really assess with the strict PRISMA criteria all the published papers, and as you can see here, there is low quality of evidence with a very high risk of bias and confounders, even in the few non-randomized comparative studies. There are anyway some implications for clinical practice. It came out very clearly that the growth rate of sporadic AMLs is generally very low, and that the majority of them actually are generally follow up with some kind of active surveillance. The probability of spontaneous rupture is anyway quite low, and therefore the need for active treatment is infrequent. Very importantly, there is no high-level evidence to suggest any cutoff to trigger treatment, and the historical 4-centimeter cutoff should be reconsidered. So it's not always necessary to treat angiomyolipoma when they reach 4 centimeters in size. When we come to treatment, actually, the data says that nephron-sparing surgery seems to be more effective than angioembolization in order to avoid recurrence and secondary treatments. So we have now new recommendation that actually tell us to treat angiomyolipoma either with nephron-sparing surgery, as I said, or alternatively with selective arterial embolization when tumors are large, but there is no recommended threshold for intervention, in females of childbearing age, in patients whom follow-up or access to emergency care may be inadequate, and of course, when there is persistent pain or acute or repeating bleeding episodes. Coming to prognostic factors, I just want to stress that there is now a strong recommendation to use the new WHO ISO grading system over the classical Fuhrman grading system. And also, there is really a recommendation to increasing the new prognostic models, either in localized and metastatic disease, to guide our decisions. When we come to treatment for localized RCC, of course, the strong recommendation to partial nephrectomy for patients with T1 tumors remains, but there is increasing interest for the role of partial nephrectomy also for larger T2 tumors. There are some meta-analyses that have been published, actually few studies, few well-performed, good quality, non-randomized comparative studies comparing radical nephrectomy and partial nephrectomy for CT2 tumors are available, and they actually show lower blood loss and lower complication rate for radical nephrectomy, but on the other hand, a lower tumor recurrence and lower cancer-specific mortality for partial nephrectomy, although of course there is some selection bias. And we have also results from a German multi-center cohort with long-term follow-up for patients treated for CT2 tumors. And once again, there seems to be, as you can see, a significantly longer median overall survival and cancer-specific survival for patients who were treated with nephron-sparing surgery. Again, selection bias might be there, but it's interesting. There are also emerging data from the collaborative study on the role of robot-assisted partial nephrectomy, which is feasible, definitely in experienced hands, with acceptable perioperative and short-term oncological outcomes. It's interesting to see that the authors compare in a propensity score match study robot-assisted partial nephrectomy with minimally invasive radical nephrectomy for these tumors, and actually they came out seeing no significant difference in 5-year overall survival and in 5-year disease-free survival. While on the other hand, of course, the 5-year freedom from the novo EGFR below 45 millimeter per minute is much lower for patients who had a partial nephrectomy. So at the end, partial nephrectomy for larger CT2 masses is feasible and finds the best indication, of course, in patients with imperative and relative indication, where the maximum should be done to preserve the already impaired renal function. But of course, this should be done in experienced hands. So we have now actually a new recommendation. It's a weak recommendation to offer partial nephrectomy to patients with clinically T2 tumors and a solitary kidney or already chronic kidney disease, if technically feasible in experienced hands. There is also a great issue because there are studies, retrospective studies, that are showing similar oncological results for tumor ablation compared to partial nephrectomy. We have now some meta-analysis published showing actually no significant difference in postoperative renal function, lower perioperative complication rates for tumor ablation, similar cancer-specific survival, but of course we have to remember higher local recurrence rate for tumor ablations and better overall survival for partial nephrectomy. Again, we don't have any randomized study, but the signal is this. When we move to T1b tumor, we have to be very careful because there is a 2.5-fold increase in cancer-specific mortality according to SEER data for those patients who have cryoablation compared to partial nephrectomy in these patients, again, PT1b tumors. At the end of the day, we came out with a systematic review of the guidelines, like a systematic review showing the quality of the guide of the other systematic reviews published, and we observed that all the systematic reviews published have low confidence rating, and all but 2 were rated even with critically low. So we could not come out with a significantly different recommendation. Thermal ablation can be recommended to frail patients with small renal masses, but we have to discuss with patients always about the harms and benefits with regards to the oncological outcomes and complication, and we should not routinely offer ablation for tumors that are larger than 3 centimeters and cryoablation for tumors larger than 4 centimeters. And also there is a signal to increasingly perform percutaneous renal biopsy not at the same time, but before tumor ablation in order to select the best patients for this kind of treatment option. Regarding adjuvant treatment, we know that there are several studies published. All these studies were negative. There was no signal advantage with TKIs on overall survival. There was YES-TRACK trial that was positive for DFS. We are still waiting for the results of the adjuvant trials using the immune checkpoint inhibitors. At the present time, we confirm there is a strong recommendation not to offer TKIs, and also a weak recommendation to offer sunitinib, which has some advantage in disease-free survival, while with no impact on overall survival, and some related toxicity, of course. Coming to surgical treatment for metastatic RCC, we clearly recommend that the decision to perform cytoreductive radical nephrectomy in the setting of metastatic disease should be always done in the context of a multidisciplinary team. Of course, we know that the Carmina trial showed clearly non-inferiority of sunitinib alone compared to cytoreductive nephrectomy plus sunitinib in this setting, but there's been a paradigm shift. TKIs are not the standard of care anymore, and now immune checkpoint inhibitor-based combination therapies are the standard of care. But we analyzed the exploratory subgroup analysis of all the pivotal trial of these new combination therapies, and we observed that patients with their primary tumor in place treated with these combination therapies have actually better PFS and overall survival than sunitinib. And therefore, the recommendation we gave last year for patients who were candidates for treatment with TKIs can be extrapolated to all the other new standard of care therapies. So we confirm there is a strong recommendation not to perform cytoreductive nephrectomy in poor risk patients. We should not perform also immediate cytoreductive nephrectomy in intermediate risk patients with an asymptomatic synchronous primary tumor who require systemic therapy. In this patient, we should start systemic therapy upfront. A delayed cytoreductive nephrectomy will be discussed with patients with the right clinical benefit from systemic therapy. In patients with a good performance status who do not require systemic therapy, there is still a recommendation to perform cytoreductive nephrectomy, and the same is true for those patients who have also metastases that can be fully resected. The field of systemic treatment, there has been always many changes. In 2019, there was only the nivolumab, ipilimumab combination therapy as a standard of care. Last year, the results of the KEYNOTE-426 comparing pembrolizumab plus axitinib with sunitinib showed a significant advantage for this combination therapy in terms of overall survival and progression-free survival in the intermediate poor risk patients, and also for PFS in the favorable risk group, although there was not a significant advantage in overall survival. And this combination therapy became a new standard of care. This year, the results of other two trials have been published. The CheckMate 9ER trial compared nivolumab plus reduced dose cabozantinib with sunitinib, again for the treatment of metastatic RCC. And once again, there was a significant signal of an advantage for the new combination therapy, either in terms of progression-free survival and in terms of overall survival. And the efficacy was observed across all the risk groups and was independent of the PD-L1 status. More recently, at the ASCO GU this year, Rob Motzer presented the results of the phase 3 CLEAR study that compared in a 3-arm study lenvatinib plus pembrolizumab with lenvatinib plus everolimus and sunitinib, again in metastatic RCC. And once again, this combination, especially lenvatinib plus pembrolizumab, had a great response rate, very high, 71%, with 16%, which is amazing, of patients achieving a complete response. And once again, a very significant advantage in progression-free survival, with a hazard ratio of 0.39 and also in overall survival. So right now, these new combination therapy are standard of care in all risk groups. So there are now 4 combination therapies which are standard of care in the intermediate and poor risk group, in all risk groups, while, as we remember, ipilimumab and nivolumab are not an option for favorable risk group. And of course, in patients who cannot receive or tolerate immune checkpoint inhibitors, TKIs, they are still an option, sunitinib, pazopanib, and cabozantinib only in the intermediate and poor risk group population. It's important to stress that these combination therapy with the use of immune checkpoint inhibitors should be used in centers with experience of immune combination therapy, because there are significant toxicity and some not negligible lethal toxicities, and appropriate supportive care should be available in the context of a multidisciplinary team. Also, a new recommendation is that in those patients where the combination therapy and have some treatment-limiting immune-related adverse events, the immune checkpoint inhibitor can be stopped and treatment should be continued with the TKI. Regarding second-line therapy, the recommendation is to use nivolumab or cabozantinib in patients with failed prior TKI, or any other VEGF-targeted therapy that has not been used in first line when there is a failure of the new standard of care combination therapies. Another important message that came out from this phase 2 randomized study, the RESOL study, looking at the role of adjuvant therapy after complete resection of metastasis in the setting, of course, of metastatic disease. This study used sorafenib, and there was no significant impact on relapse-free survival of the use of adjuvant sorafenib after complete metastasectomy. So there is now a strong recommendation not to offer TKIs to metastatic RCC patient after metastasectomy with no evidence of disease. To conclude, there was also some important update on follow-up after local treatment. We are putting together a large database, the RECUR database, and we are trying to build up a recommendation based on evidence. There are now new updated follow-up schedules that you can find, of course, printed in the guidelines that are based on risk profile. It's very important that we strongly recommend to base follow-up after treatment on the risk of recurrence that should be assessed with the use of the Leibovitz score for clear cell RCC or the UCLA integrating staging system for non-clear cell RCC. Of course, follow-up should be intensified in patients with a positive surgical margin, and we should also consider, this is a new recommendation, to curtail follow-up when the risk of dying from other causes significantly exceeds that of the recurrence. Thank you very much for your attention.
Thank you, Alessandro. I think a very brief and concise summary of what's new in renal cancer, and renal cancer guidelines in particular. And I went through the Q&A and while you did your presentations, and there is I think it's a team there that says, what's really the indication for a biopsy of the tumor, and which patients do the guidelines recommend a biopsy of the tumor? Yes,
percutaneous biopsy have been increasingly used in the last few years, but historically, we all know we were not using it at all. Biopsy should be used when they can change clinical management. They are particularly important in comorbid elderly patients who are still a candidate for an active treatment, but for which we consider active surveillance or, for example, tumor ablation. In these cases, biopsy is important because, of course, benign tumors can be easily, of course, followed with surveillance, while low-grade tumors are good candidates for alternative treatment to surgery. High-grade tumors, in my opinion, should be better treated with the surgery upfront. Biopsy, of course, has also a very important role also in the setting of metastatic disease in order to really characterize pathology and allows the choice of the best treatment for each patient, especially, of course, in those patients which are the majority right now, which will not be treated with the cytoreductive nephrectomy.
Clear. Most of what you said is related to clear cell renal cell carcinoma. Is there anything new for non-clear cell renal cell carcinoma?
In the setting of metastatic disease?
Okay.
Well, there are no major, unfortunately, news. The quality of the evidence is relatively low, and we are still stuck with some low-quality evidence that is recommended the use of sunitinib over the other TKIs for this kind of tumor. The main recommendation for these tumors is to try and enroll them in clinical trial whenever this is possible. First of all, to really increase the evidence and giving us the opportunity to really know better whether the new combination therapy, the immune checkpoint inhibition-based combination therapies in this setting, which is not completely clear at present.
Okay. Another question, Alessandro, and I want to make that the last one, but the other ones you will be able to address online is a new kid on the block of focal therapy, local therapy of the tumor, either metastasis or primary, is stereotactic radiation therapy. What's the view of the guidelines panel on radiation for renal cancer?
Well, I think that there are interesting new data on the role of radiation therapy for kidney cancer. We all know that historically we're not giving any consideration to this kind of approach. There are data that the radiation therapy can be effective. However, we are still in an experimental phase. And so again, I think that we should work as a group, as urologists and radiation oncologists together to build up more experience and to try and confirm the good, promising results we have now in order to be able to translate them into guidelines recommendation. Right now, there is no recommendation to use these approaches and they remain experimental.
Clear, very clear. Alessandro, thanks. There are some other questions online. If you have some time, you may address them right now. That would be very nice. Thank you.
Thank you very much.
So finally, we want to complete the the ESU course here now on prostate cancer. And let me continue. The prostate cancer panel is a multidisciplinary panel with radiologists, radiotherapists, oncologists, as well as urologists. And these are the bird's eye view I want to give you on the 2021 update. Prostate biopsies, grading, a little bit on active surveillance, biochemical recurrence, what's new in M1 disease, non-metastasized, castration-resistant prostate cancer, a little bit on genetics, which is really new for this year, and the follow-up of patients. So what's new for prostate biopsies is that now the guidelines think that transperineal biopsies outperform transrectal biopsies for the sole reason that the number of patients with sepsis and admission for infections was significantly lower in the transperineal route compared to the transrectal route. An issue for biopsies is always infections and how to avoid that. And the guidelines panel reviewed, together with the infectious guidelines panel, the use of antibiotics in prostate cancer patients that undergo biopsies. And in Europe, we have an issue with fluoroquinolones, and they are banned now by EMA for reasons of multiple resistance, and fosfomycin might be an alternative there. It's important to remember there are no randomized controlled trials on the use of antibiotics in transperineal biopsies. I know there are hospitals not using any antibiotic prophylaxis, but please remember infections do occur even after transperineal biopsy. So these are the recommendations, and I just highlight two as being very strong. The guideline panel prefers transperineal biopsies over transrectal biopsies, and please be careful with quinolones. So something that has been there for a while is Gleason grading. It's from the 70s of last century, and it seems now it's replaced by ESUP grading. And here's the table, and there is a strong recommendation to use ESUP grading groups instead of the old Gleason score. So what to do with active surveillance? I think we are loosening the criteria a little bit, in the sense that now Gleason 4 patterns are eligible for active surveillance, as is suggested by the Canadian consensus adopted by ASCO. It has to be remembered, though, that any grade 4 in the biopsies is increasing your risk of metastasis threefold over longer periods of time, so care needs to be taken. In the detective initiative from the prostate cancer panel guidelines, 109 experts in the field voted on whether Gleason 3+4 is eligible for active surveillance. And 70% disagreed that it was an exclusion criteria per se. And they stated that it can be used, Gleason 3+4 patients can be eligible for active surveillance when their tumor is small and their PSA is low. There's one thing very important, and it is already included now in the Prius criteria for active surveillance. It can be Gleason 3+4, but it should not contain invasive cribriform growth. And this is now the guidelines for active surveillance in intermediate risk prostate cancer patients in the 2021 guidelines. So go for the smaller tumors and patients with low PSA, but definitely do not recommend active surveillance for patients with Gleason 3+4 and cribriform growth. One thing for cribriform growth is important to remember, and I think the pathology community recognizes that it may not be easy to reproduce the grading of cribriform growth. And if you look to prostatectomy specimen in this series, 50% of cases was disagreed on the fact whether there was or there was not cribriform growth by a pathology panel. And I think it's important to remember that when you ask your pathologist to say whether cribriform growth is present in the biopsies. Now, to continue to biochemical recurrence, the EAU has proposed the biochemical recurrence risk score being low risk when the recurrence after local therapy is more than a year. The ESUP score was 3 or lower, and the biochemical recurrence rate was, the PSA doubling time was longer than a year. Anything else, any of these criteria being satisfied will make it a high risk. And why is that? And this is an update from 1.5 years ago showing that patients with a high risk biochemical EAU score, they have a 5-time higher risk of having a disease-specific survival. And interestingly, this finding was independent of the surgical margin at the prostatectomy. So this is the recommendation. Please remember, it's a weak strength offering monitoring to patients, in particular, I think older patients that have a low EAU BCR score. So what's new in metastasized hormone-sensitive prostate cancer? And I summarized here the tables that are presented in the guidelines because I think they very nicely show the data from the studies that have been done so far. All studies, 3 presented here, combined, show that there is a benefit of adding docetaxel to ADT in patients with primary metastasized prostate cancer. And the benefit is a hazard ratio of 0.77, which translates in a 9% improvement of 4-year survival. Are there alternatives? Yes, there are. There is abiraterone, now studied in 2 large studies, finished some years ago, and they show a benefit of abiraterone in combination with ADT. And in an ad hoc analysis from the STAMPEDE study, it was shown that the same benefit applies to low and high volume disease. So what's newer is the enzalutamide and the apalutamide studies, ENZAMET and TITAN, that came out last year. And they show that indeed, again, if you combine them with ADT, there is a survival benefit with a hazard ratio of 0.67. And again, this applies to patients with low as well as high volume metastasized disease. So important for this year, I think it's to note that do we distinguish low and high volume for patients with metastasized prostate cancer with respect to treatment selections? No, we don't. The recommendation is for all patients with metastasized disease to be treated with a combination of ADT and any form of systemic therapy. So what's even newer now is which systemic therapy is to be preferred. And there are very little to no large comparative studies for the different agents in combination with ADT, but a network meta-analysis was just presented this spring showing that yes, there may be some differences and advantages in this case for overall survival for abiraterone when compared to apalutamide, docetaxel, and enzalutamide. But if you look to toxicity of the different agent combinations, then you see that yes, docetaxel does worse with respect to toxicity, and enzalutamide may have the least toxicity as used as a combination therapy. So what should we do with the primary tumor in patients with metastasized prostate cancer? Well, the STAMPEDE study suggested that in low volume disease, local radiotherapy to the prostate may improve outcome. It should be noted, though, that in this so-called STAMPEDE-H study, only 18% of patients had ADT plus docetaxel, which is basically the standard at the moment. So it's difficult to translate these findings to the current recommendations of the guidelines. And again, it's also difficult to say whether ADT plus docetaxel plus local therapy to the prostate, so-called triple therapy, is to be recommended because study data are lacking at the moment. So do we need to target the therapy to the metastasis? And the opinion of the guidelines panel is that there is currently no data that metastasis-targeted therapy with either surgery or radiotherapy improves overall survival, but the initial studies with other endpoints were promising. Now, briefly on non-metastasized castration-resistant prostate cancer, I'd like to mention 3 large studies, the SPARTAN, PROSPER, and ARAMIS, on different ARTA agents, and they all confirm that there is a benefit of adding these agents in patients with castration-resistant prostate cancer, non-metastasized. What is the difference for these agents? They all postpone the time to metastasis, but there is a difference in toxicity. If you compare fall fracture and rash, then these were statistically significantly lower for darolutamide if you compare it to the apalutamide population. And similarly, there was less fall dizziness and mental impairments if you compare darolutamide to enzalutamide. But if you look to the survival benefit, then it seems that enzalutamide and apalutamide might be slightly better and preferable over darolutamide. So even complex is the question, how should we combine and sequence the different ARTAs, being Abi, Enza, Apo, or Daro? And sequential analysis shows that there is limited benefit of adding any of these agents after failure to one of them. there is a highly selected population in which it may be considered that at more than 24 weeks of abiraterone, they may benefit from addition of enzalutamide in case of failure, with a median progression-free survival response of 8.1 months. So what's new for last year, I think, is the PARP inhibition. In patients that lack the BRCA1 and 2 gene, mutated either in germline or in somatic in the tumor itself, inhibition of PARP may prevent cells from repairing their DNA and lead to cell death. So 2 large studies led to the FDA approval of olaparib, and 1 phase 2 study to the FDA approval, provisional FDA approval of rucaparib. And they both show about a 5 months overall survival benefit in comparison to standard of care. So what's important then, at least, is to the question of genetics. Mutation analysis is needed in these patients if you select a PARP inhibitor for their treatment. So in those cases, mutation analysis is recommended, and it is strongly recommended because it may lead to improved outcome and improved treatment in case of PARP inhibition. It is also important, the guideline panel thinks, to distinguish between germline mutations which are in the gametes in comparison to somatic mutations which are in the tumor cells and cannot be inherently transmitted. So why is this important? Because we know that germline mutations in specific genes I've mentioned here in this table, in particular BRCA2 and ATM, and a little bit of BRCA1, may increase the risk in offspring of developing prostate cancer. In particular for BRCA2, it has been associated with cubiform growth and worse outcome in patients with prostate cancer, and it's often found in patients with prostate cancer at a younger age at the diagnosis. So these are the studies that were used to come to the recommendations. In Israel, data showed that BRCA1 and BRCA2 mutations lead to a significantly higher risk of prostate cancer detection, 8 versus 3%. And a similar finding was done for the IMPACT study done in Europe, showing that yes, if you screen these men for prostate cancer, their prostate cancer is found earlier and may be more significant than in patients that did not carry that germline mutation. Then coming to the recommendations for genetic testing in prostate cancer, I think it's important that we made several new ones for this year, but please note the strength of the recommendation, and most of them are weak. And this is not because we think that there is no evidence that it is increasing the risk of prostate cancer if you have any of these specific mutations as a family member. But the problem is that we do not know whether screening these family members will improve their outcome with relation to prostate cancer. And the recommendations, I will not read them, but you can see them in the guidelines. So what's new in the follow-up of men with metastasized prostate cancer? And we all are used to use PSA to detect early progression. And early progression, for example, in the charted study as defined here, was a rise of PSA over 50% of nadir with a lower threshold of 4 and even lower than 2 over 2 if the nadir was lower than that. So now in the charted study, all men underwent routine imaging and PSA. And it is interesting to see that if you look closely at the data, that in almost 1 in 4 men, clinical progression preceded PSA progression. In other words, the PSA did not rise significantly while their clinical progression was significant, as being defined as increase of metastasis or complaints. And even more interesting is that if you look to these patients that had clinical progression without PSA progression, the overall survival was much worse for the patients that did not have a rise in PSA. So using PSA only in patients with metastasized disease, you may miss those cases that you could really help. And for that reason, the panel thought it was sufficiently shown that although with a weak recommendation, but it is important to remember that even patients without a rising PSA, they may be difficult to select, but consider imaging maybe yearly in order to find these tumors that do progress without a PSA elevation. So this is my last slide. I think summarizing what's new in my view for the 2021 guidelines in prostate cancer is that, yes, the transperineal biopsies are now the recommended route for the reason that they give less infections. If you do grade the prostate cancer for uniformity, we recommend you to use ISUP instead of Gleason. If you want to go for active surveillance, the indications are broadened a little bit. Gleason 3+4 can be chosen if the tumor is small, but important is that it should not contain cribriform growth. If you look to biochemical recurrence, in particular after prostatectomy, there may be identified a group of men in low risk that do not need any salvage therapy. For M1 disease, I think it's important to remember that combined EDT with any systemic therapy may be beneficial, and the toxicity of the combination may dictate the choice. In non-metastasized castration-resistant prostate cancer, we have 3 options to delay metastasis development, and again, toxicity is slightly different. In genetics, we have genetics BRCA2 and BRCA1 as being predictive of response to olaparib, but the genetics also predict the risk of developing prostate cancer in family members potentially containing the same mutation. And in follow-up, I think it's remembered, it's my last point, that yes, PSA is not always predicting progression in patients with metastasized disease, and early imaging or regular imaging in these patients, I think, is warranted. I thank you for your attention, and I like to ask Jose and Alessandro, because I hadn't time to look at the questions that came by.
Thank you, Hank, for a very, very nice update. There is a question. It's asking you whether there is any role for genetic testing to stratify patients who are candidates for active surveillance for low-risk prostate cancer.
Yeah, that is a good point. It's a relevant point. What we do say in the guidelines on that is that we think that in particular young men with BRCA2 mutations do not lend themselves very well for active surveillance for the fact that they have, in particular, a more aggressive phenotype for their prostate cancer. There is no data supporting any screening in patients that are considered for AS other than the recommendations for screening in response to family history or history of patients with family members with more advanced prostate cancer as is stated in the guidelines.
Thank you. Another question is regarding, you partially responded already, regarding the role of metastasis-directed therapy, especially radiation therapy for oligometastatic prostate cancer. We ask you for a comment on the actual role.
Yeah, well, the guidelines are very careful there. The only data we have is that there is sufficient evidence in randomized studies that show that there is a delay in the need for start for systemic therapy in patients that had metastasis-targeted therapy, but there is no data showing a benefit for survival. Another route now is chosen by the fact that we know that radiotherapy in combination with ADT is more efficient than radiotherapy alone. So some studies are now addressing the question whether adding ADT to radiotherapy targeted to the metastasis may improve outcome. And I think we have to wait data on that before we can make any strong recommendations there.
Thank you very much. Then there are another couple of questions. This colleague is stating that Stampede stated that the adverse events of docetaxel and abiraterone were similar after 1 year of treatment, but the meta-analysis that you presented showed that the adverse event of docetaxel was much more the other option in patients with M1 PCA. What is the reason for this, in your opinion?
Yeah, good question. I think it's the reason of timing. So this analysis was done earlier within the 6 months, and the questioner is correct that he states that after 1 year the toxicity may be less. So it's a matter of early toxicity rather than delayed toxicity.
Great. Maybe a final one. They are asking you whether you know why the M-arm of the Stampede study, which look at the effect of rucaparib, was discontinued. Do you have information about that?
No, I have no information on that. Sorry for that.
Great. I think.
I think yeah. No, I see the question now coming in.
Oh.
Yeah. No, I'm not sure about. I'm not sure about answering that that question. No, thank you.
Great. I think.
Yeah, for the sake of time, I will address the other questions if we can stay online. So typing them in, that's no problem. I like to thank everybody. I think we stayed well in time. Please remember, in order to get your points for the course, you have to address the questions that are online as well. And within 24 hours, the course will again be available, being transmitted on the EAU website. And I wish you a good night. And I thank my co-panelists for their extensive and hard work on reviewing their guidelines. Thank you very much. Good night.
Bye-bye. Thank
Bye,
you.
everybody.